It's my great pleasure to introduce the next speaker, Professor Bengt Jonsson from Department of Economics, Stockholm School of Economics from Sweden. So please, the floor is yours.
Thank you very much. It's great to be here. I'm going basically to say the same as Professor Henke. I will do it under a different title, and I will do it differently from what he's doing. What I will focus on is, of course, how we get the empirical basis for the relation between health and wealth, because it is a complicated association, because it goes in both direction. Health produces wealth, and wealth produces health. It is thus needed to have very sophisticated models of economic growth to unveil the effects of health, and this is what we call the macroeconomics, and health as an input factor in macroeconomic theory. I'm going to talk also about health as an investment in human capital. It's the same here, and that is the microeconomic foundations, which goes back into health economics, and then I will end with some policy conclusions. And of course, being an economist talking of wealth, I start with Adam Smith and his inquiry into the nature and causes of wealth of nations from 1776. And of course, why is that relevant for us today? Well, it's very relevant because Adam Smith, he outlined the concept of the gross national product as a measure of national health. So if we haven't had Adam Smith, we wouldn't have the German figures which you were presented here before, because that's basically in his period. So what he says is that wealth is not money. Wealth is what you produce, and that is, of course, then what you can consume. And of course, that it means it's the nature of the per capita product, and that is dependent on the proportion of the population who is productive in the company, in the country. And it also depends on the skills and efficiency with which the productive labor is employed. It's rather easy to see the impact from health on this. I've taken another illustration here on the relation between health and wealth, just to show that it's a complicated association. And this is from Gapfinder. It's a presentation technique which is developed by Hans Roslind, who is a professor at the Karolinska Institute in Stockholm. And you can see here he is looking at wealth and health. He is defining health as life expectancy is one out of many possible definitions of health. He has income per person on the other axis, and you can see, of course, a very clear relation between health and wealth here. And of course, you can do it. You can take a different scale. You can look at the more affluent countries as the more poor countries, and you will see that the same element holds. But how do you actually entangle the more detailed relation between health and wealth and health? And for that, of course, you need rather sophisticated economic models. I'm not going to bore you with that. You will definitely fall asleep. Macroeconomic growth models are beautifully complicated. They are loved by economists, but very complicated. But just to take one example here, this is from Robin Swift. This is a Journal of Health Economics from 2011, a rather recent one, shows that 1% increase in life expectancy results in an average of 6% increase in the real GDP and a 5% increase in the GDP per capita. And then, of course, also in these co-integrated models, you can see the effect the other way around as well. And then, of course, it's rather interesting because he looks at data from the 90s and 20th century, and it seems to be, and I think that's maybe also interesting, is the data are extremely stable over time. There is another reference here. Is Robert Barrow, is a Harvard economist who is a very well-known growth theorist. This is a paper from 2013. He is reviewing basically the whole field of health and economic growth, and you can see here in his regression model here. Life expectancy is a very significant variable in determining economic growth, and the way he is explaining it is that an increase in life expectancy from 50 to 70 years basically increases the annual growth rate with 1.4%. You can think about 1.4% year after year after year is of course a tremendous benefit. We are happy these days if we get 1.4% in the growth rate in the economy. So these models are very complicated, but luckily also we have about 20 years of experience now in economic growth theory. There is very nice books. This Health and Economic Growth, Finance and Policy Implication by Guillem Lopez Casanovas and his co-workers, which summarizes up this here and goes into the details. But if I actually follow what Robert Barry is saying, I think he actually states in his paper from this year that actually health has been neglected in economic growth models. So according to him, I think this will be probably a very important new area. And I think this is very important because economic growth models, that's something with the finance departments are dependent on, forecasters and on. So now we are getting health into the macroeconomic policies. Another way of just looking at it, we are talking very much of sustainability of healthcare system, and we are not really so precise exactly how we are defining it, but the way you can look at it is that it has to do with mobilization of resources, which of course we have seen, looking at particularly from a Swedish perspective, we have in many countries had the same and long period of mobilization of resources until the 1970s. Then of course we got into a period where we basically in Sweden we haven't had a growth in the share of the GDP going to healthcare for 30 years. We went into a period of changes in the structural processes of healthcare. But if you are looking at it today, it is not so much a mobilization of resources, structure and outcome. It's basically about how to transfer in these resources into outcome. It has to do with health and quality and the quality of care. And this is very important for this aspect, because it's not healthcare expenditure per se who creates, it's health who creates growth. Healthcare expenditure don't necessarily create growth. Well, they can create growth, but so can expenditure in the car industry, as they do in France, for example. They subsidize cars instead of the healthcare. But the importance of well, Germany does that as well, sorry to say. Healthcare expenditure per capita, as you see here in Europe, we have huge variations in, and this is a problem which we are not going to address today. It's a different problem. But what we, of course, need to do here is, of course, using investment in health as a way of creating incomes and wealth, and then, of course, also rising the healthcare expenditures to get them closer. But sustainability has, as I see it today, it has to do with mobilization of resources, the structure of processes, but it mainly has to do with how effective we are in transforming our resources into health. And how are we doing that? Well, we were talking about health and human capital, and Selma Mashkin, and I think if she would probably could be described as a mother of health economics, as Adam Smith is the father of economics, or at least a grandfather. She wrote a paper already in 1962 pointing out that investments in improved health has economic benefits in terms of reductions in premature mortality, reduction in early retirement, reduction in absenteeism, and of course increasingly also reduction in presenteeism, that actually we are going to work, but for a number of reasons we are not as effective in production as we could be. And why is this important? Well, if you are looking at the cost of brain disorders, this is a study I did together with the European Brain Council for 2010. Here we have the economic burden, you can say, an economic cost of just brain diseases is 798 billion euro. But if you are looking at those costs, with about 1/3 are the direct healthcare costs, 1/3 are the indirect costs, and these are the direct non-medical costs. So if we are not invested in health, or we are cutting down on investment in health, we will get the cost back either in indirect cost or in direct non-medical cost. And this is true for both neurological disorders and mental disorders. And of course, what we more and more need to do, of course, is that we have to provide the empirical evidence for how these relations look. And of course, more and more we are having these data. This is data on the cost increase with progression in multiple sclerosis. These are the mild, and this is the moderate, and these are severe cases. And it's interesting to see when the disease progresses, healthcare expenditure don't progress very much, but all other expenditure progresses: indirect cost, informal care, and services, etc. for patients. So that's where the big costs are, and that's of course also where the big benefits are if we can make the necessary investment. There is another point that I would like to look at here, and that is also the health status in the period 55 to 74 years old. It's very important, not because I myself is of that age group. So quite a lot of other people here are in the same age groups as well. What we know, and this is Swedish data, is actually that the health status is improving all the time in these age groups. If you look at share of persons without reduced work capacity, we can actually see that it is rather stable going up. Here is only for the younger women here, but it actually goes down. So you can see that, well, actually 50 to 60% has no reduction in work capacity, but you can also turn it around and say that 40 to 45% actually has a reduction in work capacity. Well, and why is this important? Well, because we are talking about retirement age between 55 and 75, and we can see from a health perspective here there is obviously not a very clear dividend. But of course, if we should be successful in increasing the retirement age, we have to make the necessary in investments. So what we need to do, of course, is that we really have to take a social perspective when we are looking at health. In the same way as Professor Henke also did, we have to look at all the effects, because health has effects in many parts of society. And also this societal approach is of course what we are taking when we look at environmental, transport, safety programs, etc. So also when it comes to our healthcare expenditure, we have to take a social approach. And unfortunately, we can see, particularly in times of austerity, we can see that the perspective getting more and more narrow. And you are just looking at, of course, the small dollar, euros or kronor which you have, and trying to use them as narrow as possible. But we really need to make the argument for a social perspective. And just one more point which I like to, before I come to my last slides here, is that investments in health, if it is an investment, it means that you are taking the cost now and you are getting the benefits later. And in times of recession, we usually do investment in education, labor force program. We do investments in infrastructure as well. We should always say that in times of austerity, this is an opportunity to make the investments in health. It's not the time to do the cutbacks, which many, of course, have some. So when should you do the cutbacks? Well, of course, the cutback and the healthcare expenditure should be contained in times of high economic activity, when opportunity cost of resources is high, when there is a lot of other opportunities for the labor force, etc., to be employed, which means, of course, that we have to run surpluses in our budgets at some time. We can't run constantly losses, so we have to a successful investment in health, of course, also includes that you are successful in containing healthcare expenditure during certain times, which of course also could be helpful for the healthcare sector to contain cost inflation. So just like to end with 3 observations, which I think there is empirical evidence for when it comes here. And the first is that investments in health affect growth, but there is also evidence that directing these investments to the populations with the poorest health is particularly important. It is that there is a complicated studies and so on for this, but there is some papers and so forth, so we always should look into this as well. We should of course always look also at outside the healthcare sector in healthy lifestyles and health environment, because what produces health and growth, or produces growth, is not particularly healthcare. It is the health economy, but it is health which produces growth, and health could be produced in also outside the healthcare sector. And then of course I think what is really important, particularly for sustainability, not only for the healthcare sector but basically for the public finances and pension systems and so on, is that we have to look at investment for a healthy workforce in the ages of 50 to 70 years in the future. This is when we know that it takes longer and longer time for young people to get into the labor force. They are not going into the labor force at 15 anymore. They go in maybe at 25 or go into 30. With a better health also, we need to extend that period. We need to extend the retirement age, and that of course is good not only for economic growth but also for the public finances. Thank you very much.